Okay, Joost and Erje, do you hear me?
Yes, we do. Hi, welcome back to Rotterdam. We're here together again, as mentioned, Rutger, myself, Leanne, Louise, Stefan, Marleen is here, and Rick is here. So we have quite an interesting case prepared for you today, and I will ask Rutger to introduce the case.
Absolutely. So if we can see the slides, yes. This is a relatively young patient, a 69-year-old female, had symptoms of dyspnea on exertion. And her history is remarkable. She had severe COPD, underwent lung transplant in 2018. And that's basically her most important history. So next slide. The ECG. Nothing to write home about, I think. It's no conduction disturbances. Next slide. And then the LV function is preserved. No other abnormalities in the valves except for a severe aortic valve stenosis. The coronary angiograms also fine. Some luminal irregularities, but no focal severe stenosis. So the most important or most interesting part is the CT scan. And for that, I would like to give the word to Rigshospitalet.
Thank you, Rutger. So I will dive right into the CT scan. Over here, we can see the annular measurements, and we see that indeed it is a small valve with an area of 382.9 and a perimeter of 71.1. Scrolling upwards, we see that the calc is severely calcified with already an Agatston score of 1060 2 years ago, and a membranous septum at the depth of 3.8 millimeters. Additionally, there's also worth noting that there's a horizontal aorta with an LAO 14 and caudal 19 optimal projections, and a cusp overlap view at REO 2 and a caudal 45. Then onwards to the femoral arteries, we can see over here the right femoral artery, which is somewhat calcified in the distal sections, but more proximately there's hardly any calcification. And on the left side, there's also some distal calcification, but the diameters are just a bit larger, so that will be the preferred site of access. Then onwards to the sentinel embolic protection measurements. So we see over here that there is hardly any tortuosity in the aortic arteries, and there's also no calcification in the brachiocephalic trunk and the left carotid artery with dimension sufficient for sentinel embolic protection. And with that, I would like to give the word back to Rutger.
Yes, so the patient went back into our heart team. There was consensus to go for a TAVI procedure, obviously because of the major thoracic surgery she had 5 years ago. But the challenging part is that it's a patient with a small annulus, so small anatomy. Also, I consider this anatomy to be a very shallow sinuses, relatively low left main takeoff, a horizontal aorta, and there is peripheral vascular disease, and also there we have a small anatomy. So there was a consensus to go for transfemoral TAVI via the left iliofemoral trajectory.
Yeah. Yeah, so maybe we'll pause here for a second. I got the impression we got a couple of minutes to do the introduction before going to Copenhagen, but maybe a few minutes to discuss, and then I'll let you move forward.
Yeah. So a question to Giuseppe. Giuseppe, you have access to a portfolio of devices. A horizontal aorta is what is your go-to valve platform there?
Yeah, this is an important point. Actually, what I prefer is to go with a short frame valve, because I prefer to go with a knob and to be horizontal with the knob. I know that there is a discussion about the accurate neo, etc., but I have to admit that sometimes with a tall frame valve, I have 2 or 3 cases that I have had some surprises in terms of, micro rupture at the level of ascending aorta.
Yeah.
Long-term follow-up.
What is your
long-term follow-up?
Adam? Yeah. Adam, what is your take on that? Because obviously, I don't think you have all the valves available, commercially available now in the US. How does that determine your strategy?
We have gotten better results with horizontal aortas with the Medtronic platform, with the newer generation, and a little bit more flexibility. So I tend to look more at the coronary risk here and the shallow sinuses to help make my decision as to what's really going to be the best for that aspect of it. And then I think, and then I'd make either the taller frame or the shorter frame work from the standpoint of the angle. So it'd be nice to see it, a little bit more, or talk a little bit more about what that real risk is.
Okay, and then maybe Kendra, for you, the patient is only 69 years old, but has a history of a lung transplant. Do you agree that this is high operative risk?
Absolutely.
Okay, that's clear. Okay, Joost, 2 more minutes. What are you going to do in the next 2 minutes?
So 2 minutes. So what we did is a single axis strategy. We took a 5-French sheet in the superficial femoral, a 8-French sheet with 2 proglides in the left common femoral. And we implanted, simply because also of her age, a sentinel embolic protection filter through the right radial. With respect to the valve choice, we had several arguments we just discussed already. Horizontal aorta, so more than 49 degrees. We know it's called horizontal, and perhaps better off with a self-expanding system like the Accurate. Supraannular valve because of the area of 380. Clearly small. SMART trial now at ACC will hopefully provide some guidance, but I think also that is an argument to pick the Accurate. And then coronary access obviously is something that with the Accurate also may be favorable. So with these 3 arguments, we opted for a strategy with the Accurate small valve. So the idea now is to put in the eye sleeve and then move forward with crossing the valve, doing the assessment, and hopefully show you the implantation live.
All right. With that, I think we can move to Copenhagen. And Ole is waiting for us for an LAA closure. So let's go. Hi, Ole.
Hey, Nicolas, can you hear us?
Yes, we can.
Hello, welcome to Copenhagen.
Good to see you.
All right, good. Welcome to Copenhagen. Let's go straight into the case. I will very quickly introduce. It's me, Yusuke, our Japanese fellow. We have Sus on the scrubbed-in nurse, and then we have Nils, our imager. So let's go immediately into the case presentation. So eyes-guided LA closure. So to say it's going to be eyes-guided intracardiac echo, there's no anesthesia in the room. So next slide. So this is a 70, if you can see the next slide. So it's a 76-year-old female. You see the body size on the right-hand side. She's known with arterial hypertension, atrial fibrillation, of course. And she has actually a double risk. She has had transient ischemic attacks 2 times before and also an intracranial bleed. So she has absolutely a good indication for an LA closure. She has also a high CHETS-VASc of 6 and has BLED of 3. So next, otherwise she has a preserved ejection fraction, no important valvular disease. However, now we just went in with the eyes 5 minutes ago, and we see that even without doing anything, she has a little bit of pericardial effusion around the heart. So I don't know, she's not known with heart failure, but anyway, the ECG shows atrial fibrillation, and in the labs, nothing particular. Next. And then, of course, very important for us, if you do eyes-guided LAA closure, CT is key for us. So this is a kind of a chicken wing / windsock LAA. You see here, especially from posterior, that there is a chicken wing component. Next slide. And then, of course, the sizing. We're going to do this case with a Watchman Flex device. So then it's important, yes, next slide, please, that we measure the ostium. And here you see the ostium is around 17 by 20, not too elliptical. Next. This is then even a more advanced sizing. This is something experimental still with Trumentio. We have a project with them where we can measure the whole LAA dimensions throughout the whole appendage, actually. And then you see, actually, this is very interesting because you can see, indeed, it's between 16 to 20 minimum to maximum diameter, and it's not very tapered. So next slide. The optimal implant view, that's going to be RO 30 to 35 and just a little touch of cranial. So this is also beautiful that we can simulate this on the CT. Next slide. Then the transeptal puncture, also that we can see what is the best trajectory to be in coaxiality with the central axis of the LAA. That's going to be an infra-posterior transeptal puncture, so a very classical transeptal puncture, I would say. Next slide. This is then simulations that corresponds as well. So an RO 30 cranial 5 kind of projection gives us the best fluoroscopic projection. And the next simulations of a 20, you see a 20 Watchman Flex could go in, but it's minimal compression. Maybe the right side could be acceptable, but still if you go for the next slide, then we see a Watchman Flex 24. And you see that either in a proximal, distal, or even more distal position, we have much better compression, between 15 to 30%. Probably we go for the middle one. On the left-hand side, you see quite some shoulder. It would be acceptable, but ideally, if we could go for the central simulation, that would be optimal. So next, that's just the plan. So percutaneous LA closure and local anesthesia, ICE guidance, a 14 French delivery sheet, and a Watchman Flex 24. So let's go straight into the case, because that's the most interesting one. What did we do the last 15 minutes before you came to us here? We have, of course, we need 2 venous accesses, 1 venous access for our delivery system, for our LA closure device, and 1 venous access for our 10 French sheet, where the ICE catheter, this is a ViewFlex ICE catheter, goes through. We also have a radial, that's just because we don't have an anesthesia, we want a continuous arterial pressure measurement. And also sometimes we use it for our pigtail if we do fusion imaging. So what we're gonna do now first is the transeptal puncture. So for this, we're gonna use something, well, I wouldn't say new, but something outside the usual. So it's not the usual transeptal kit, but this is the VersaCross system. So you see this is a kind of a shaped wire, but at the tip where we can give some RF, some energy. So now this is just a 6 French sheet in the groin. So we're gonna introduce this here, this VersaCross wire. So let's introduce this. And then we have to look on the fluoro. Very often this wire finds itself the way up into the vena cava superior, as you see here on the fluoro. Yeah, that's good. Then we can take out the 6 French sheet. So we take out the 6 French sheet now. And now the VersaCross sheet is gonna come. This is a great sheet because we can shape this sheet ourselves in the shape we want. So it typically comes with only a 30-degree bend, but I bended it myself with a big curve, 90-degree. So Joost, you can put it on. So this is that VersaCross system. So we don't need any needle for this. It's just we're gonna do the transeptal puncture with the wire, yes? And by giving some energy. So you hold the wire, I'm gonna go in.
And Ole, this is conventional 2D ICE that you're gonna use, right? This is not 3D ICE.
Yeah. Correct. It's just conventional 2D ICE. That's it. So that fits in a 10 French. If you would use 3D or 4D ICE, that needs a 14 French, or at least the one we have here in Europe, the Siemens one. So that's not what we're going to use. So then if we look on fluoro, we see here the wire. I'm pulling in the wire here, just to the tip of the delivery system, like this. Okay, good. Now I also have a pedal, another pedal with my foot to give the energy. So now I'm gonna go already a little bit posterior. You see the eyes image too, where you see the fossa, and the right-hand side is the superior part, left-hand side is the inferior part. So I'm coming slowly down now with my VersaCross sheet, pulling slowly back as you normally do for transeptal puncture.
There's tinting.
There is already tenting, apparently. Yeah, indeed, but that's still quite superior.
Oh, yeah.
Go a little bit REO. Yeah, so we're quite mid. I'm going to go a little bit more inferior, preferably, because the more inferior, the better for LA closure. Yeah, like this is already better. I can even go a tiny bit more. Yeah, there.
And it's also posterior. Here's also anterior, and you can see that we have posterior in the septum.
So now we have inferior posterior. Okay, good. So now I'm going to make ready for my energy. So I give energy and I come out with the wire. Yeah, you see, and I'm across.
Wow.
Yes. Do you see me across now?
Very elegant.
Niels?
Yes,
Yeah,
very
I see you
elegant.
across.
Yeah. Yes, so we don't need any needle. And go back to AP. The beauty of this system is also that theoretically you don't even have to change system. Now there's a little bit of resistance here going through. That's typically not too much of a problem. Yeah, I think we went across. No,
yeah.
It went across. All right. So what you can do is, but I won't do it. You can keep this wire now, in fact, in the left atrium, and even bring in your delivery system of the Watchman Flex. You can do it, but because I use ICE, we have to give full heparin, by the way. Because we use ICE, I do like still to take this out, this component now out, and go with a classical stiff wire into the left upper pulmonary vein. Because that's a guidance also for my ICE catheter, where I have to navigate with my ICE catheter. So I don't use maybe this VersaCross to the full potential, but it's definitely possible. I've been doing this. You see also, by the way, on the ice, we have a very, very nice inferior puncture. And that's really key. To me, that's really key of a successful LA closure typically, is being able to puncture inferior enough. That's really the key for success. So let's go forward to the wire. Joost? Okay, good, you're there. Okay, forward to the wire. Yeah, let the wire go. Okay. Go a little bit back. Yeah, that's good. Let the wire go. All right, good. This is in the left upper pulmonary vein now. Let's see if I can bring it even a bit higher up. It's not always possible, but by going a little counterclock. All right, that's good enough. All right, good. Let me give now the stiff wire. So this step is not an absolute must if you use VersaCross, because I could have kept, as I said, just that wire, that kind of safari-like tip curl, pigtail curled tip. But I do like to put my stiff wire here now in this pulmonary vein, because it's going to guide me when I go across with my eyes. Yeah, keep the wire forward there. Yeah, all right.
And what is the
So now we're gonna
technique now
change
to get your eyes in? What do you do with your hands now? Is it a systematic maneuver?
Well, there are two things to look at. You can either look on your eyes when you see your wire really in the triangle at the top of your eyes image. That's the moment that you know you're very close to your wire, and then that's the moment to cross. But I do, honestly, I always look at both eyes and fluoro. Yeah. So, but what we're going to do now is still pre-dilate. We're going to pre-dilate with the delivery system. So now, of course, Niels, he already wants to attempt to go across. But typically, I always, if I'm standing here alone doing this, I always wait for this, and I go, as you see now with the delivery system, this is the True Seal delivery system, 14 French for the watchman flags. I'm going to go across. And we know it's a little bit of a more tight fossa. So I really have to push a bit, which is not usual. I'll have to push a little more, even. I have quite a bit. If this is not enough, then we really have to even use a balloon. That's super rare, to be honest, that we have to do that. I would still prefer that we can do it the regular way. Wait, Niels, you hold the wire here, Joost?
Sometimes if you go.
Yeah,
just
now we're
with
across, you see?
Yeah.
We were across. I'll do it once again to show you and to pre-dilate further for Niels. Yeah, you see now we're nicely across. Okay, so Niels, now it's your turn to go across.
I'm across.
And he's across, okay? Then we go to our implantation view. That's an REO. And typically it doesn't take long. Like yesterday, we also did 2 appendage closure. I think it took less than 2 minutes to get across, to be honest. So it's, of course, in the beginning, that's where there's some learning curve to get that ice catheter across. But yeah, that goes typically nice. Now you see it's still, it's really a tight fossa, but we're across. All right, good. Nice. Now we take everything out here. Yeah, let's get it out. Now it's the moment where we have to start finding the appendage, of course. I'm going to pull a little back. It's not bleeding back. No, it's bleeding back. Yeah. All right, good. Okay, good. Let's bring in I do a pigtail. I use a pigtail to try to find my appendage. Open up here a little bit. Yeah. Okay, that's just a J wire that goes in, and now the appendage goes in. So you see the ice catheter is actually placed in the pulmonary vein, in the left upper pulmonary vein. That's where the ice catheter is positioned now. Okay. Good. You have the wire there. You have it? Not yet? Okay, I'll pull it a little bit back. Yeah, all right. So now I introduce this pigtail. Okay. We're already in an REO. No, we're just in AP still, I see. I go back in my REO view. Now REO 30 and a touch of cranial. Yeah, like this. I will zoom on in. Okay, so now it's the moment to, you hold the wire, Joost. Yeah, hold it. Hold it. Yep, all right, good. Now I have to go a little bit anterior clock, like this, and if I push forward, then I'm straight into the appendage. Yes, we know this all from CT, so there's actually no surprises. You hold this pigtail and wire, I push a little bit forward. So that's the great thing about using CT. You don't come to surprises. You know exactly how that anatomy is going to be. So it's not like in the old days from 10 years ago that you start that case and you don't know what's going to happen. No, you know exactly what anatomy you get in front of you. So now it's a moment it's not an absolute necessity, but we can give a little bit of contrast here to show you. Yeah, right. I can even pull this a little bit back. Yeah, right. We will give in a small cine here now with the you always have to make really good sure that there's no air, of course, in this structure in your delivery. Yeah, okay. So this confirms here our CT. You see it's not too big because on the marker bands you see on the delivery sheet, you see the one marker band at the tip of my delivery sheet, and then the first one, which is quite a distance from there, that's 21 millimeters. So it clearly shows it's smaller than 20. It's around that 14, 15 only, but it's elliptical. We know it's 15 by 20 or 16 by 20 on the CT. So I would stick to my 24 plan, to be honest. So I think we prepared it because otherwise we knew this is going to be a step where we're going to lose some time. So let's also assess how deep we are on ice. Maybe Niels, you can comment on that. What do you see on ice?
I see that you are well past the circumflex and past the landing zone.
Yeah, so you have indicated the circumflex with that small cross there. Yeah, the small plus, and then indeed, yeah, all right. It's not too deep. There is depth, but it goes very tapered still in the very distality. It becomes very, very tapered. But okay, we go. I think the delivery sheet is deep enough. So let's take now the pigtail out, and let's take the device. Yeah, all right. So this device, the Watchman Flex, which is great. What is great about it is that it comes actually in a long sheet, which you can flush, as you can see here, and that makes actually that it's less prone to get air in it. It's actually really nice because of this. So okay, you're gonna flush. Yeah, flush to flush. We connect. We introduce into the delivery system. Yeah, it's in now. Okay, I don't open it unnecessarily too much. Also, all right, good. Now on the fluoro, if let's replay the previous image again, you can also see the rib. You see that top of the rib there, that shadow of the rib. So I can go a little bit deeper than that. So I take that a bony structure or any random structure I take as a reference. So I know a little bit how deep I can go. Now you see the device is coming there, line to line. So now you have to take a good view on my hands here on the table. So you see this device has now approached line to line. So then I stop moving the device forward with my right hand, and I will retract with my left hand the sheet until it clicks. It makes a real click. You can hear the click. Okay, so now this is now locked. I can forget about it. Now I can open here on this hemostatic valve at the end, which is good closed. Yeah, all right. Good. I'm going to move a little bit to the right. So you see the device came even a little bit back. I will move it a bit forward. Yeah. All right. Also on ice, you see very nicely how deep I am. So I will unsheet now mostly because I'm quite deep in. Yeah, you see I'm pretty deep into the appendage. You can see that I'm more than a centimeter on echo. Typically, if you're more than a centimeter or roughly a centimeter distal on echo from your circumflex, that means that you can just do an unsheet maneuver. Yes, if you cannot get the depth of 1 centimeter, then you have the freedom. Then you cannot just unsheet, but also push the device a bit and unsheet your system. But now I have really, really good depth, so I think I'm going to use actually just unsheet, to be honest. And I do that slowly, like I'm going to unsheet. Voila, that's it. So I just unsheet it because I knew I was more than a centimeter distal, and I give a small push to invaginate it. All right, I think that looks quite nice. So let's prepare for a small injection. We can already see on eyes, it looks actually really nice. We don't have a lot of shoulder, so it looks indeed exactly like the simulation I showed with the 24 in the middle one. That was my preferred one, I would say. It's not always possible to do it like that. Of course, it depends on the complexity of the anatomy. But okay, let's make an injection here with a little bit of contrast. I just fill the sheet. If you give me now a full syringe, then I give a real nice cine, so everybody can see what kind of position we have. I did not do a tuck yet, so I'll give a shot now here with contrast, injection. Yeah, and that looks really nice, to be honest. It looks excellent. It's immediate closure also. You see there's hardly any contrast going into the appendage. And also the contrast that goes in is an extremely slow washout. So this is typically a sign that this is going to completely occlude. So we're going to have a complete occlusion. Also here you see on the Commandant Ridge side, we don't have shoulder at all. And on the mitral side, this we can appreciate on the eyes, of course, we could already see that. There's only a minimal, yeah, there you see that. Maybe Niels, you can show that small shoulder there, what we show on the circumflex mitral side. So it's minimal. It's like a 3-4 millimeter, I would say.
Yeah.
Yeah,
That's
there
the circumflex. And
you see the circumflex. Maybe you can indicate it with a cursor or something.
Oh, yeah, we'll do like this.
Yeah, there, that's a circumflex. And then you see, so I will do a tuck test now. And then we're ready to release it, I think. And also, yeah, that's another thing. So how to assess actually the compression. I know that the company officially recommends to measure the device on echo, but to be honest, it depends very much whether you really have a slice going through the middle of the device or not. So you can do that at the crown, but I think it's also really good with this device that you can assess it, the configuration of the device. How does it look? Is it a bell shape, Hoddock shape? So I think this is in between a bell and a Hoddock shape. So it elongates quite a bit, but that's actually really good. That means there's 20 to 25% compression on the device, which is also in line with these simulations. So maybe Niels, have a good picture now, take a bit distance from the appendage maybe now, because I'm going to do a tuck. So for that, Niels can come a little bit out of the pulmonary vein like he did now. Yes, indeed. And then he takes more a frontal view of the appendage. So I'm going to do a tuck test, a gentle tuck test here. So now I have some traction on the device. All right. And that doesn't seem, I especially keep an eye on the distal part, and that doesn't seem to move at all. Yes, it kept immediately completely his configuration as it was. On eyes, it still sits the same. Also on fluorus, it's the same. So I don't think even we have to give contrast here to confirm this, and I think I'm going to release it. If the panel has another opinion, maybe it's interesting to hear.
Well, this was super fast, and I think this really looks like a complete closure. Adam, do you have any comments here?
No, that's a fabulous example of how to minimize this procedure. Have you found any benefit to 3-dimensional ice over 2-dimensional ice for this application?
No, to be honest, look, it is as such. You need, during the case or the pre-procedural planning, in one of the stages, you need some 3D assessment. So it means if I have perfect 3D imaging pre-procedurally, I can do it with 2D imaging during the procedure. If I don't have great 3D imaging pre-procedurally, then of course, you need 3D imaging, either TEE or ICE-based 3D imaging during your case. So you need at one of the stages a 3D imaging to be 100% sure about your sizing. But as we do with the CT beforehand, we can do multiplane reconstruction, great 3D reconstruction. We are so confident about our sizing. I think the last couple of years that we have to change device size during the case, to be honest, it's really less than 1 or 2% of the cases. But okay, some patients maybe cannot have a CT, let's say for the renal function, then we could go forward and maybe not have anesthesia. Then you can go forward with just complete 3D eyes. Because with 3D eyes, the nice thing is you can also do a multiplane reconstruction and make a really reliable sizing of your appendage. So that's the only advantage, I would say.
And do you ever use any other views other than the left pulmonary vein? Or no? Or do you just keep it on the left pulmonary vein?
Good question. I mean, very often in the majority of the cases, 80% of the cases, I'm standing here alone with no imager. So then during the case, I typically keep my eyes in the left upper pulmonary vein during all these maneuvers. If I doubt, the only thing like Niels is doing now, so now he takes a more mid-atrial view. He takes a distance and leans back in a way with his eyes, and then you get this picture. So that's also great if you doubt whether there's leak, then you typically go to this view, put some color on it. And then like we did yesterday, actually, when we doubted about some too much shoulder on the mitral side, the maneuver to do then is to do really retroflex and hover over the mitral valve. And then you place your ICE catheter just parallel with your mitral annulus plane and look upwards. Yes, and then you can really, really nicely appreciate the shoulder or whatever there is, or that you're suspicious of a leak or whatever on the mitral side. So these are the only 3 positions you do with your ICE catheter.
Yeah, it's a beautiful.
So I think we released, as you
nice.
can see, and it sits really super solid. It's there's no leak here. This is the mid-atrial view. There's no leak whatsoever to see. I'm really confident that in 3 months from now, when this patient is going to come back for a control CT, because that's what we do, we're going to probably see a full closure. I mean, I'm quite confident. And what is
Giuseppe,
good, it's
any
good
comments?
to avoid a really too distal implant too. Yeah.
So,
Giuseppe.
yeah, a couple of comments. So first of all, this is this your default strategy? In our case, you go like that, and also with other devices, or just with this one?
No, always. We do already since 2011, since the last 13 years, all the cases with ICE-guided LA closure. So we don't, this is our default strategy. Yeah. Also for all devices. Yeah.
Very effective, very elegant. Ole, thank you very much. I think we have to go to the other room in Rotterdam because I think the valve is already in there. But thank you very much for your top demonstration. And I think you are signing off, right? Because you have to run. But a superb demonstration and a very elegant LAA closure. So thank you very much. Thank you, Yusuke. Thank you, Niels. And we move now to Rotterdam. Have a good one. Bye-bye.
Success.
Okay, Joost, we're back with you.
Welcome back. So, as promised, we started with engaging with the eye sleeve, which went very smooth. We just took a 38 Turmo wire and advanced the sheet without any problems next to the long 5 French braided sheet. Went very smooth. But then this patient started to become very restless. Initially, we thought she had a stroke, but it appears she's actually quite adequate. So at this point in time, she's doing fine. But since she was so restless, we decided to continue with the valve implantation and not put her into more distress by waiting unnecessarily long. So what we can do is that we just show you what we did, because I think we recorded all the steps. So we have the sentinel in that we've showed you next. So we started, as we typically do, with a 20 millimeter balloon based on the minimal diameter of the annulus. So with the balloon first slipped a little bit out, then slipped a bit in, but we thought this was good enough for somebody with an Agatston score of 1000, which was not exorbitant. And this is the stage where we come with the valve. So we stored the whole thing just to be able to show you what we did. So everything went in very smooth, actually. We always check if we cross the arch whether the device doesn't capture the filters, and then we stop in the ascending. And that's the stage where we want to check the commissural alignment. Rutger, do you want to comment?
Yeah, so this is, it's important to always verify what is the projection. This is the 3-cusp coplanar. And in case of inaccurate, we look at the 3 posts at the base of the stabilization arches and also at the free cell, if you can see them. In this case, we can see them. On the right-hand side, you see the free cell. And on top of that, you see 3 posts with 2 on the left and 1 on the right. So if we would need to correct, we would we would clockwise rotate this device, but we would do that in the 2-cusp overlap view. If we can see the next slide, next film. So this is the right-left overlap view. And here also we see immediately on the right-hand side the free cell, and on the top of that we see 1 post on the right and 2 posts on the left. So with this view we were confident that we achieved commissural alignment only by going in with the delivery system with the flushboard go at 6 o'clock. So we continued. Joost, maybe, or?
Yeah, so here we continued. We crossed the valve. It's important with this system that the last movement you make is a push-forward movement in order for the valve to not pop out during the deployment. It's a top-down deployment. We check the positioning. You see the pigtail is nicely in the nadir of the valve. The marker is just on top of the annular plane, and this is where Rutger started to do step 1 of the deployment. So you slowly start to deploy the valve. See the crowns popping out. Kept a little bit pushed forward here at this stage. Oh. It's no time to rush. Hemodynamics were completely stable. See the arches here deploying. And that's the final point of step number 1. And that's the point where you need to take out the release pin. And here we start rapid pacing. Something Boston now recommends during the final stage of the deployment, which you need to do very quickly to keep the valve as stable as possible in order to reduce the risk of pop-outs. So we paced at 120, and then at a proper position of the valve. Let me quickly take out the filters in the meantime, and then maybe in the meantime you can discuss a little bit or provide us with your feedback.
So, how is the patient doing? So the patient is under a local anesthesia. She's wide awake.
Wide awake. Okay. She's fine. Maybe you can show the hemodynamics. She's mostly restless. She was already extremely restless and anxious before we actually started. We gave a little bit of midazolam in order to dampen a little bit the most severe part of the distress. Just took out the filters. Neurologically, she's fine at the moment.
Okay.
So that's it. But she's moving and really done with the procedure. So we will continue with the closure.
Well, wait a minute. Giuseppe, you had a question?
Yes, the pulse pressure seems to be 110. So actually, because I didn't see the check for aortic regurgitation after valve implant.
Yeah, we can show the angio. Let's show the angio with the post-PCI assessment. We did 2 angios, one in the coplanar view and one in the cusp overlap. This is pre. Can we show the post-PCI, the post result, please? Ja. Heel even nog, mevrouw. We halen de buisjes eruit.
Okay, so we still have the pigtail in the LV, but there is no sign of any regurgitation here, so that is good. We have widely patent coronaries.
Even aan de kant anders.
That's nice. And what about the gradients? Can you show us the hemodynamics after the valve implant?
We'll show you the gradients. It was actually hemodynamically very nice result, no gradient. And the post-implantation AR index was 38. We started with 40. We ended with 38. LVDP was 8 when we started, 9 when we ended. And you see there's actually no gradient, low filling pressures. We actually gave a little bit of fluids at the start of the procedure. So now perspective, hemodynamics, excellent result.
Yeah.
This is interesting because the pulse pressure here is low.
Yeah.
The
what is low?
The pulse pressure during
pulse pressure, it's 80.
Yeah, seems
80.
lower.
Yeah. But the blood pressure when we started was, they wrote down 80 over 40, but I think it was also somewhere around 160 over 70. So that was basically, let's say her normal blood pressure and consequently her pulse pressure.
Yeah, and it reflects the stiffness also of the vasculature. I think what you're demonstrating is a very streamlined approach. Basically, this is the theme of today, right? We had a very streamlined LAA closure under local anesthesia, and now we see a streamlined TAVR procedure. And what is quite of notice is that there is no TTE or TEE involvement here. So Joost, you're not gonna do a TTE here.
No, we're not. I have no reason to believe there's significant AR or whether there is a significant or relevant pericardial effusion. Hemodynamics are still fine. That's basically it.
Adam, what is your take then? Are you still insisting on having a TTE in the cath lab?
No, we do often have one, but I would say that we don't use it every time. So I'm with you. If you still prefer to do an angiogram and things look good and your hemodynamics good. I don't think you necessarily do it. You know, it's amazing. I have noticed that sometimes the predicted annular angle being severe like that, when you wind up doing your procedure, it just doesn't seem to come into play. And if you look, you know, how do you think of it? You know, if you look, that valve is pretty well squared up. It is not very canted, and it's still pretty vertical, right? It's not as horizontal as you would have thought it would be based on the CT, and it's a perfect example of this feature that I find as I continue to do this. But sometimes there's this discordance between what the CT predicts and then what you actually see when you're in there.
Oh yeah, I agree. Kendra, how important do you feel is this supraannular design? Is this something that is clinically relevant, or is this more an echo thing than an invasive thing? What is your opinion on that?
Well, I do think that with the data that we have, that hemodynamics have been better with the supraannular valves. And I appreciate the argument that maybe it's just an echo finding, but it seems to make sense.
Yeah, and obviously we will see the presentation of the randomized controlled SMART trial in at ACC. Do you want to do any predictions there?
Well, I can't give you any predictions. I'm a little too close to it, but I would love to hear what Giuseppe and Adam think.
I could try. Okay, Giuseppe, what do you think?
I think that will be a significant difference in terms of gradients, but for me, what remains unknown is the clinical impact of that.
Yeah, Adam, what your thoughts?
I have no knowledge of the data, and I agree that the gradients will be different, but I'm not sure there'll be a difference in clinical outcome. That's my guess. How about you?
But Kendra, well, you know, I bet you that the echo gradients will be lower with the Evolut valve, but I hope that there also is a systematic assessment of the invasive gradients. Kendra, can you comment on that? Do we have invasive gradients before and after the valve procedure for all cases in SMART?
Yeah, I'm gonna hold off until the presentation for ACC on making any comments, but I agree with you that would be really important. It would help answer this question about whether or not this echo difference is a meaningful difference to the patient. But ultimately, we're going to have to follow these patients. We're going to have to look at the long term, because it also may be that 1 year is too short to really demonstrate a major clinical difference.
Yeah. I think that is a very important comment. Go ahead, Giuseppe.
Going back also to the partner 3 versus core valve low risk, actually, if you look at 4 years, the breakdown of the valve, the difference is 3 millimeters of mercury. So we will see, you know, what is going to happen in the SMART.
Yeah. Joost, let's go back to you in the cath lab. Have you been closer? Have you been taking out a large sheet?
Before we close the ProClarge, but in the meantime, patient is still moving, so she also took out her own radial sheet, so we had to quickly put in a TR band. So we're done now. We just have to make a final angio of the common femoral, which we can show you live. This is something we routinely do, as you know. We have the 5 French sheet and the superficial, which allows us to check the arteriotomy closure, check for patent hemostasis, and allows a very elegant bail-out route in case there is a need. But in this case, there is no need. Yeah. Alrighty. So that's it. Comments?
Yeah, there's a little stricture there, but that probably is clinically irrelevant. So this is our practice. We do this single access site approach where we have this 5 French sheet in the superficial femoral artery that allows us to have a very easy assessment of the final large bore arteriotomy closure. So how do you do that, Adam? Do you still do crossovers and then make an angiogram, or did you walk away from systematic angiography after a large bore closure?
Yeah, we still use the other leg for the pigtail, and then we do a non-selective iliac angio at the end with the pigtail and the distal aorta just to check. Because what would you do if you wanted to fix that common femoral now? Would you use your SFA sheath, or would you have to go up and over?
Yeah.
Yeah.
Yeah, Joost, go ahead. Why don't you comment?
That's indeed what we do. It's 6 French, so it's very easy to put in balloons, wires, whatever you may need. If you need a stent, obviously you may need to upgrade to 7 French, but that usually is no problem if the superficial, which we screen on the CT scan up front, is okay in terms of caliber.
Yeah, so everything basically is in place to have a bailout. But the need for covered stents these days is I think 1%, so very low. And yeah, it really also expedites the procedure more and more. Giuseppe, what is your practice these days?
My practice is to do a non-selective contralateral injection. And I have a question for you too. Is actually when you get a puncture of a superficial artery, we know that there is a relative increase in minor vascular complication. How much is the rate of minor complication in your center based on the puncture of the superficial artery?
Negligible, negligible. And so that, again, we also look for this, and we do our planning by CT scanning. So we want to really know what is the quality of that superficial artery, what is the size of it. So we're not going to approach superficial arteries that are smaller than 4 millimeters. Obviously, that is a no-go area. But otherwise, it's very straightforward to use a perclose at the end of the procedure. And yeah, for the time, I mean, we have done this as our go-to approach in the last, I think, 4 years now, and well, I haven't looked into the exact data, but I can't recall major complications. Elie, what is your thought on that?
I agree with that, but as you always mention, Nicolas, the most important part is that you do the echo-guided access, right? That you puncture at 12 o'clock in a calcium-free section of that vessel, and then if that goes well, then the access goes well as well. So.
Yeah, it's very controlled, and obviously there are the steps to do before you close. I mean, we check the blood pressure is preferentially around 120 to 140. We check the ACT. We give some protamine if needed. We do that routinely with Manta. In case of proglides, we don't routinely do it, but we always keep the option. We check the ACT before we close. You know, all these steps that all of you know, of course, are critical in order to reduce the number of complications.
Yeah, and can you also briefly comment on where this patient is going next? Is she going to the ICU? Is she going to the CCU? Or is she going back to the ward? What is the setup?
Well, this particular patient is a little bit restless, but I think there's no reason to do it differently than we always do. So we keep our patients at the holding area, which is just 5 meters away from here. And if the patient is doing well, then she goes to the step-down unit immediately. So patients do not go to the cardiac care unit or ICU. I think, yeah, it's in many cases, if not most cases, the patient can mobilize this evening. In this case, it's going to be a little bit more problematic, but usually it is possible.
Yeah.
Yeah. Kendra, is that also similar at Emory, that you have no longer ICU beds taken in by these TAVI patients?
No, that's correct. They can even go directly to a telemetry floor, but oftentimes will go to a angioplasty recovery, the same type of place that a PCI patient would go, and then transfer to a tele bed later. But it's the same.
Yeah. This tele monitoring, is that still essential in your practice, Giuseppe?
Pardon, could you repeat the question?
So the rhythm monitoring, is this still mandatory in your opinion? after TAVI?
No, it depends on at the end. What I think is important to see what is your conduction disturbance, things like that. But actually, if all the same, we go, we get the patient to the ward and the day after will be discharged.
Yeah. Wow.
Yeah. The future.
Yeah.
The present.
Well, apparently the present, yeah. So, but I agree. Yeah. So if you have 0 changes in conduction or PR intervals, then nothing is going to happen. We already know that from previous data sets. So I think it's a very sound approach, and this is where the field is heading to, right? It's very streamlined, but also very lean. There is no need for all these redundant medical attention and whatnot in a straightforward TAVI procedure.
Mm-hmm. Yeah, yes, because the risk is to get the patient infected, in the hospital. So the earlier the discharge, the better it is for the patient.
Yeah. And
the hospital is not an healthy place. So this is it's not healthy to stay 1 day more, 2 days more in the hospital.
So maybe we can briefly go back to the discussion we had on the bicuspid aortic stenosis. So Kendra, what we are facing is quite some resistance among the surgical community to collaborate and take part in a randomized study of younger patients with bicuspid aortic stenosis. What is your take on that? Do you feel that is justified to try to not to be involved, or do you feel that given the fact that we are really talking about this less access, rather than less invasive strategy without the need for all this additional monitoring should also be appropriate for the true low risk and younger patients?
Well, I think first we have to, I agree, we're asking a very important question. And then we have to design the right trial to be able to provide the data to answer that question. And unfortunately, what's happened with the single-arm registries of the low-risk trials is that the exclusions were so high that you can't really answer the question, is bicuspid aortic stenosis treatable with TAVR? Because really they were Sievers ones. So I think it's a really important trial. We need to encourage our surgical community to get on board with randomizing the patients so that we have the data to support what is best in this patient population.
I agree with that. So Joost and Erje, you are also finishing up. I see that you already are descrubbing. I think we are in the last minutes of this session. Is Rick still around?
Rick is still... no, Rick left.
Oh, okay. But anyway, I think it's good for the audience that Rick Adrichem is one of our research fellows that ended his fellowship or is about to end his fellowship tomorrow. And just to say to everybody who wants to hear it, this is really... he did a very good job, and he will obtain his PhD within the next 6 months or so. And we wish him all the best in his next career, because he's now going to start his residency in cardiology. So I wanted to put that also here on the live. So thank you very much, Rick. Also, thank you, Erje and Joost and the entire team in Rotterdam for a sublime case. And at the same time, we don't go back to Copenhagen, but also they really showed us a superb demonstration of a streamlined, very lean LAA closure under local anesthesia and ICE guidance. So thank you very much for the live cases, guys. Thank you.
Thank you.
All right. Any final comments or thoughts, Adam, Giuseppe, or Kendra?
No, I think those are great demonstrations of the way we're headed, right? It's minimal access, minimal sedation, home as soon as possible, right?
Yeah, that's it. That's it. All right. With that, I think we are coming to the end of our session. So thank you very much, Adam. Thank you, Giuseppe. Thank you very much, Kendra. Also, once more, a shout out to Michael Mack for an outstanding keynote lecture. please stay tuned with us for the main program, but we now have a 1 hour break when we have in that hour the Woman as One initiative, who will have a breakout session to discuss more controversies. I now leave the stage to Victoria Delgado for the Woman as One solutions. See you in an hour.